Good afternoon, students. We'll see about congenital deformities. Okay. That is a first one is a congenital talipes equinus varus. That is a CTV. That is a club foot. CTV is the vague term used to define the number of abnormalities in the foot region. The true etiology of the congenital club foot is unknown. The idiopathic is a mechanical intrauterine pressure is after the delivery. Then ischemia of the calf muscle. Then genetic factors. Then secondary is the paralytic disorder arthrogryposis multiplex congenita. Then we will go for CTV pathoanatomy. The small bones are the smaller. There is a talus faces downwards. Calcaneum is a small. Then joints. Ankle is a equinus deformity. Subtalar is a inversion deformity. Metatarsal is a forefoot adduction. Metatarsal forefoot adduction and cavus. Then muscles and tendon. Posteriorly is the tentoagilis muscle affected. Medially by the tibialis posterior. Flexor digitorum longus. Flexor salis longus is affected. Then capsules and ligament. Capsules of the ankle and the subtalar joint. Middle is a talonavicular ligament, spring ligament, and deltoid ligament. Plantar fascia and ligament, and the enterosseous ligament, most commonly affected. Then clinical features, that is a detected at birth, then brought during early infancy, brought during the late infancy and early childhood, then brought during late childhood. The examination, normally the foot dorsiflex to touch the chin of the tibia. Foot is smaller in equinus than varus and adduction. Heel is small. Then deep skin creases on the back and medial side of the foot. Then bony prominence of the callus is on the lateral foot. Then outer side of the foot is convex. Then that is this diagrammatic representation is shown about the cleft foot deformity in the child. Then we'll go for CTV's diagnosis. Mainly for X-ray, it is a reduced talocalcaneal angle, normal more than 35 degree. Then you will go for treatment of the congenital talipes equinus varus. There is a non-operative management, go for manipulation. There is a manipulation and the corrective plaster. Then you go for operative procedure, many techniques. That is a posteromedial soft tissue release technique. That is a less than 3 years. Then limited soft tissue release technique. Then tendon transfer technique. Then divert osteotomy. Then Dilven procedure for 4 to 8 years. Then wedge tracectomy for 8 to 11 years. Then triple arthrodesis for more than 11 years. Then Illuso technique for recurrent. Then you will go for CTV maintenance is mainly for splint. CTV splint, Dennis bone splint, then CTV shoes for there is a maintenance phase. Then we will go for spina bifida. The spina bifida is the congenital disorder when which the two half of the posterior vertebral arch fail to fuse the one or more level. Then we will go for spina bifida type is the occulta and cystica. Occulta is the mildest form, is the midline defected near the lamina. Then cystica is the more severe form, content of the canal prolapse, that is the meningocele, myelomeningocele, open or closed, then hydrocephalus. Then we will go for spina bifida clinical features. Usually occulta is usually nothing. There is a midline dimple of top of the hair follicle, then pigmented nevus. Then neurological symptoms are the enuresis, incontinence, weakness in the lower limbs. Then spina bifida cystica is the sacral lesion in the lumbar region, hydrocephalus, then equinovarus or calcanevalgus of the feet, then recurvatum of the knee, then hip dislocation, element type of the paralysis, loss of sphincter control. Then go for that is the spinal bifida condition, the diagrammatic representation. Then you will go for spinal bifida clinical features, the dimple represents in the features. Then we'll go for mainly for diagnosis X-ray, CT, MRI. Then spinal bifida treatment is the wound care, proper closure of the defect. Then hydrocephalus is the ventricular shunt necessary for 5 to 6 years. Then physiotherapy and splinting. Then go for congenital dislocation of the hip, the third deformity. This is for spontaneous dislocation of the hip occurring before, during or shortly after birth. Then you go for etiology is not well understood, hereditary predisposed to joint laxity, then hormone induced joint laxity. Then you go for breech presentation, then hereditary faulty development of the acetabulum. Then you will go for pathology. The femoral head is dislocated upwards, a small capital epiphysis. The femoral neck is antevated, acetabulum is the shallow, ligamentum teres is the hypertrophied, fibrocordalis labrum is the folded limbus, then a structured capsule, then muscles are shortened. Then clinical features are both in the from pediatrician, early childhood, yes, asymmetry of the jaw increases, then limitation of the hip movement, click sound is present. Then older children is a peculiar gait present. Then you go for a clinical feature. That is the first diagrammatic representation. The arrow mark is seen about the line. The line is in asymmetrical line present the dislocation of the hip. Then you will X-ray finding will be shown about the dislocation of the femur and acetabulum. Then mainly diagnosis for the Barlow test is positive, Woodall test is positive, Galston is a positive, telescopic test is a positive, Trendelenburg is a positive, X-ray showing acetabulum break of the Chantal line is a small head. This is the features. Okay, student, today we'll stop out the class. Then tomorrow is continuing about the classes. Thank you.